So this evening for Dinner with the Doctor, our Dinner with the Doctor, third Monday in August, I want to welcome Dr. Greg Steinke. Dr. Greg Steinke is a hospitalist at Erlanger, and he is one of the hospitalists that has been assigned to the COVID unit, or the coronavirus care unit. He cares for floor patients, and interestingly, another one of our church members, Brandon Kobos, is a nurse in the ICU caring for COVID patients. And so we have a lot of good information about coronavirus and how it's going in our community specifically. Now, we previously, if you go to dwtdhickson.com, you can find a talk that I did. It's been 3 or 4 months ago now, kind of introducing coronavirus, and we have a lot more information now. A lot of that, well, some of that information is actually out of date now. So I'm looking forward to this update from Dr. Steinke. I also want to point out that Dr. Steinke is leading out in a trial of lifestyle medicine and coronavirus. He and I are working together on an examination of the effects of hydrothermal therapy and coronavirus. And so, Dr. Steinke, how many patients do we have on that study now?
16.
We have 16 patients that have done some hydrothermal therapy, and we're still enrolling patients as the pandemic kind of goes along. And we're going to compare those patients to those who didn't get hydrothermal therapy, although this is not a randomized controlled trial. It's kind of just a feasibility trial to see how things go. So maybe he'll tell us a little bit more about that. But without ado, I'm going to have prayer, and then I'm going to turn the time over to Dr. Steinke to proceed with his talk. Let's bow our heads. Dear God, we're thankful for your blessings to us this evening. I ask that you will guide in our time together this evening. Bless Dr. Steinke as he's sharing this information with us. I pray that it will be helpful. Help us to avoid fear, but also take necessary caution. We know that your desire is that we prosper and be in health, and I'm thankful that each one of us can optimize our health in many ways. And ask that you will also protect us from those things which we cannot control. Bless Dr. Steinke now as he shares. In your name, amen.
Amen.
Thank you, Eric. Really appreciated hearing about some of the things you had to share there. I thought I'd show an image that is somewhat free of COVID for a moment. You know, folks who are in the Wild Man's Brother Range there in New Zealand are not necessarily worrying about it as much as those of us who live amongst many other people. But when you can get out into nature, it's a freeing experience, and I hope that all of you are having those opportunities. Let's see here. All right, so this is a general update. I tried to choose the issues that were, I thought, most prevalent or most pertinent to this particular timing that we're going through. I have a background looking at hypertension, and we did have a book that we were able to do on that. And so I've done a lot of looking at high blood pressure. We're not going to spend too much time on that tonight. This is my usual garb in the hospital, my N95 mask. I wear it all day, and I can tell you for a fact that it is not comfortable to wear an N95 mask all day, but we do it because we love the people and we want them to do well, and we want to stay safe. And we always wear a shield in the hospital all the time. So this is our study, and we went over this a little bit last time I was with you a few months ago. But yeah, it is a case control trial, and it's a case series basically. And we have 16 patients now. We've been enrolling patients as we can. Not all the patients that obviously come into the hospital are eligible, but patients actually are finding it a lot more desirable than I realized at first. A lot of them enjoy the heat. It's interesting how when you're, your body's very inflamed, and especially amongst those who are not having much of a fever of their own, that external heat is kind of feels pretty good, and I've had a lot of patients say that. And I've learned over time also that people who are having, really strong fevers don't seem to really enjoy it as much. And we've kind of tended to leave those patients alone if they're already having a 103 fever. So you know already that corona means crown, and this seems to be one of the aspects of coronavirus is it feels like the king of viruses right now. Last time we looked at the key comorbidities, I hope you were there for that talk. It was an enjoyable lecture to give, and we know that when you have these various diseases here, that you're at higher risk. We're not going to take much time with that today. But if you have questions about that, we will go ahead and talk to you about this. Probably the number one thing from that talk is that overweight and obesity is a significant risk factor, probably one of the strongest risk factors when it comes to having severe COVID-19. And if your BMI is greater than 35, which is a significantly overweight, obese, your risk is 7-fold higher to go into the ICU and be on a ventilator. So that's pretty significant. Also, the men, we have an increased risk as well, and that is something that we have noted many times in multiple studies now. We tend to, I think, have higher levels of inflammation on average than women, and that is putting us in the hospital more, giving us severe COVID. All right, so today we're going to talk about 4 things. We're going to talk about the good news. There's some good news coming out, and I thought I'd focus on that a little bit. Some of the good news about COVID-19. I know sometimes it feels like it's only bad news, going on and on and on. So we'll focus on that for a second. I want to talk about viral dynamics. What's going on in your body when you get the infection? How's this happening? And we've learned a lot about this over the last several months. We're going to talk about assessing risk. I think this is a very important thing to understand. We still have the virus fairly prevalent in this area, and we're certainly not Wyoming or something like that where it's hardly touched them. But we'll look at that briefly, and then number 4, we'll take a look at some of the factors affecting our own immune response to finish it off. All right, so we know that there's been a lot of cases occurring in the world, and here's the currently infected patients that they have data on. There's been a lot of people who've gone through it now. Thankfully, only about 1% of the actively infected patients are serious or critical. This is one of the good news points we're about to bring up. And that's wonderful. This is a difficult graph to read with the daily new cases because there's been so much more testing in the last 2 months, 3 months. And so it's made it difficult to understand which way we're going here in terms of cases. And our deaths in the world seem to kind of be leveling off to a degree. And hopefully it stays that way and goes down. So the good news, what is the good news about COVID-19? Seems like a lot of bad news. Well, the good news is that it's actually less serious than was first thought. When we first heard news coming out of China, we had a lot of concerns, but it's actually a little bit less serious than we thought. Here's a basking shark, and he looks pretty ferocious, but he's actually not going to eat you. So that's kind of a similar comparison there. So when we looked at this data from China, and this was one of the first reports coming out of China, it appeared in Journal of American Medical Association in February. They looked at a summary of 72,000 cases there in Wuhan. And one of the key kind of graphs there, the box, just listing out some of the data, showed this, this very important piece here with spectrum of disease. And what they were seeing in those 44,000 people, according to the testing they were doing, is that they were seeing a lot of severe and critical cases. And so this became very, very concerning when you basically have 20% of the cases coming into the hospital or potentially being at risk of dying. And so that got everybody pretty much on tap on that, and got them pretty excited. So that was the data at that time. The NPR put out a news report, and I just took a clipping from it. It said, data from China show that 20% of COVID-19 patients, though, are serious enough to get sent to the hospital. That's about 10 times more often than flu. So that was in March. Now, based on our understanding of doing the antibody testing, it's more like 1 to 4%, maybe even less in some data sets. So it's a lot less than it was. And the 4% might even be a little bit high, depending on how you do your antibody testing. The other good news is that there's a lot of asymptomatic infections, and this has been coming out more and more. There's a lot of research coming out on that. Back in this report is actually published in July, but I think they wrote it a while before based on the information that's in there. And I just took one of the quotes from this Pathophysiology, Transmission, Diagnosis, and Treatment of Coronavirus Disease 2019. They said true asymptomatic infection is believed to be uncommon. And so for a while there, we were wondering if asymptomatic infection was occurring much, even though we had seen a little glimpse of it with the cruise vessel, Princess cruise vessel that got a lot of news. And we'll get into that in a second. But now, on the CDC website, they give a range. It's pretty wide variety of range there, because the studies are just wildly different. It's pretty impressive how much it can be as high as 70% down to 10% if you use the antibody testing. And I think a lot of this has to do with the age of the patient, the seriousness of the infection. If it's very mild infections, they don't tend to make antibodies as much because it just didn't affect their body that much. And so the percent of infections that are asymptomatic, current best estimate from the CDC is 40%. And so that's pretty high. And so that means that there's a lot of people out there who had no idea that they were exposed. And it suggests that we're farther along on this epidemic than we think. So here's the Diamond Princess COVID-19 cases. This was a very interesting thing that occurred in February. So, there was about 3,000 people, 3,700 people on this vessel. And they were able to identify 634 cases when they did this 2-week quarantine on the ship through February 5 through February 20. And they were repeating the PCR tests on people who hadn't done it yet. And they were able to identify 306 symptomatic people and 328 asymptomatic people. And so this kind of was a harbinger of what was to come, though at first a lot of people didn't think there was that many asymptomatic infections. They were arguing that this is just pre-symptomatic. If you follow them long enough, they will get symptoms. And they did follow these people along, not as well as they should have, but the 96 that they did follow along who had who were a case, 11% developed symptoms. So it was a relatively small amount that developed symptoms. And so there's this large percentage of asymptomatic people that are present. 21% of those on board tested positive, with 51% of them being asymptomatic at the time of testing. So 51% seemed overly high. And again, it's maybe somewhere around 30 to 40% there with that vessel were asymptomatic. And the amazing thing about the Diamond Princess COVID-19 cases is that a large majority of the people were elderly. I mean, it's amazing. Almost everybody, or the majority of the people, were over 50. And so it's pretty exciting that we can have so many older folks go through this kind of thing and remain asymptomatic. This is of course good news. Here's another good news point. New York City hospitals were not overwhelmed. We got the impression that they were while all the news was coming out. But when you look at the data, in retrospect, they did have to increase capacity because they were worried that they were going to overshoot things. But if you look at these graphs, this is how it went for them here in New York. You can see on the left graph there, patients currently hospitalized for COVID-19 in New York City. They had an increase in hospitalizations. It went up to 12,000, and then it kind of has died down here basically since July. They haven't had much going on in their hospitals on the COVID-19 front. They did have an increase in their ICU hospitalizations. You look at the capacity, 1 in 6 hospital beds was still available in New York City hospitals. They did increase the capacity a little bit there. They can, fairly significantly increase their ICU capacity, and if they hadn't, they probably would have, they would have had a little bit of an overshoot there. And so that was important that they did, but they were able to bring that under control, and that was a blessing. So the other good news is that, and this was just reported in the New York Times again today, and there's multiple studies coming out on this, is that there's evidence of immunity months after COVID-19 infection. So we know that for mild infections, you have your T cells that are more involved. When you have a stronger infection on you, most of those people make antibodies, and that is a fact. So here's some of the misinformation that we've been struggling with, I think, in the news. And I just picked this up off of my Twitter account. It says, CDC says recovered COVID-19 patients will have immunity for about 3 months. And that was just a few days ago, August 14, that came out. And that's a very misleading headline. It's not that at all. Actually, it's this. So the next day, they had the same basic report, and they changed it, realizing the error. Recovered COVID-19 patients can test positive for up to 3 months after diagnosis and not be infectious to others. Well, that's a big difference. If you don't have immunity, that is a big problem, versus you can test positive for 3 months and actually not be infectious to others, and that doesn't say much about the immunity story at all. And so let's look at these details a little bit more as we go here. So yeah, I just want to share this as well. So this Newsweek also ran with this story. Those infected with COVID-19 are immune for just 3 months, CDC says, which is completely wrong. And this epidemiologist, Carl Bergstrom, on Twitter said, "Epidemiologist here, this is absolutely false and unduly frightening. The CDC said nothing of the sort." Let's take a look at what they did say. In short, they are suggesting that immunity generally lasts at least 3 months, not up to 3 months. And so, this has been a struggle for all of us to understand the complexities of the human body and the interaction that is occurring. And so we need to read what we're reading with a grain of salt sometimes, and not jump to conclusions. So another piece of good news. The true rate of infections is much higher. This was confirmed in the U.S. On this article that came out in JAMA again by Havers, and it was a really thorough, good report looking at 10 sites in the U.S. across the U.S. from west to east. And what they found was that as follows. So Basically, the actual cases being reported, on these various websites, somewhere around 5 million, just above 5 million now. But what they actually found in these 10 sites is that depending on which site you looked at, the seroprevalence, which means the amount of people who actually had antibodies to COVID-19, was somewhere between 6 to 24 times greater than the actual cases that were reported. So that means that you take whatever case count you have in your city or in your county or in your state or in the country, and you have to multiply it. So there's a multiplier effect that you have to do to figure out where things are at, and realize that this was in March to May 2020. So this was already 3-4 months ago. So if you do a 6 times multiplier for the whole US, take 5 million and multiply it by 6, you've got 31 million cases that have already occurred. Or at the high end of the spectrum, if you did a 24 multiplier, you'd have 124 million cases that have already occurred. Some of these asymptomatic, some of them mild infections, some of them just people who never got tested, the test wasn't available. So somewhere between there, obviously that's a very wide range, but that suggests that 5 million, as we have on these websites, and even on the CDC website, they're reporting this, is nowhere close to what actually is occurring. And this is good news, because the closer we get to 50+%, the closer we get to herd immunity, and at this point, that's the only thing that's going to stop this. Assuming that we have good immunity, which we're learning that we do now in most people who have experienced this. So, hopefully that means that, so we're 3 months later now. So let's just take a middle of the road, say 50 million 3 months ago, maybe we're up to 100 to 150 million people now who have had this infection. And even though we've tried to slow it down, it's still spreading around. And so that's hopefully, good news, and then that's as close as we can get to accurate about how many people have had this at this point. So the true death rate is much lower because of the much higher level of infections that have actually occurred. So the current case fatality rate says that we currently have about 3.2%. And that's just if you take the total amount of deaths that we've had in America and divide it by the total number of cases that we know of. That's your case fatality number. So if it's 6 times greater, then it's about 0.5%. And if it's 24 times greater, then it's 0.1%. So, and for a while now, somewhere between 0.1 to 0.6% has been quoted as the case fatality rate. And the flu is 0.1. So, on bad flu years, it's around 0.1% of people die. So, this is a magnitude stronger than the flu, but it's definitely not 3%, which is a dramatic worsening. And of course, the greatest good news is that the live rate is much higher. So, that's just the flipping the coin on that. And 99% of people are alive in the USA who have had this infection. So that's 189 in 190, somewhere between there, to 779 in 780 cases survive. And so this is good news. And this pump here is an old pump in Paris, France. This is a child filling up water in Paris, France, and that reminds me of some of the old cholera studies where they took the top of this off, and people couldn't use the pump, and the cholera went away. And so and that increased the amount of people living dramatically. And so we want to see how we can do that here. So let's look what's going on in the body. We've learned a lot about this, the viral dynamics of COVID-19. So one of the things you have to understand about this is you have to understand a little bit about the testing. I'm not going to get into great detail here, but basically you have to figure out what they're talking about when they quote a study, when they're talking about COVID-19 and they're talking about testing, they're talking about diagnoses, they're talking about how many people are getting it, you really have to be able to differentiate every single time. Are they talking about PCR, polymerase chain reaction, which is the method we use to detect the actual virus in your body? Or does it have to do with the antibodies? And that is detecting if our own immune system responded to the virus. And so those are two very important, very different questions, I should say. Is the virus in me, or is my body responding to the virus? And so we use the antibodies to try to figure out if somebody has had a response to the virus in the past. Or sometimes we use it if we must. We don't like to use it as much, but if we must, we'll use it while the person's still sick, if we don't have access to the PCR. But the PCR by far is the preferred method when someone's in the active infection to see if they have the virus. Okay, so those are the two tests, and that's very important to understand that difference. If you don't understand that difference, it'll be confusion all the way around. All right, so here's a graph that says a little bit more about that. So this is the PCR, and this, again, the current infection. It informs the individual of infection status so they can anticipate course of illness and take action to prevent transmission. All right, informs patient management for the healthcare providers, and then it helps the public health a lot. And so that's the PCR, again, asking the question, is the virus in this person right now? And we use various swabs to do it, you know. And then antibody, like I mentioned, this detects whether the person has been previously infected. It allows you to identify those who are immune to SARS-CoV-2, or at least, we'll get into that a little bit more, but generally speaking, immune. If tests can detect protective immunity, individuals could be returned to work. So they're doing well, they're feeling better, they could be returned to work and could have a semblance of confidence that if they got exposed again, that probably they're less likely to have a significant, life-threatening experience. Identify individuals with neutralizing antibodies. Obviously, we care about that as healthcare people. And then facilitate contact tracing and surveillance. So that's what the public health world is trying to do. As the antibody studies start to come out, we're trying to understand how many people have actually had this, where are we at with this epidemic? Is it following a traditional curve, or is it going to throw us a curveball? So the other thing you have to understand is people who get this infection in a very mild way act differently than people who have severe symptoms in terms of the way their immune system responds. And one of the basic things when it has to do with the testing is that when you're an asymptomatic person, you have the infection, you come back positive because you got the PCR testing done and you got the swab, you probably, many cases don't come back to ever be positive for the antibodies. So this IgM is the short-term antibody that body makes right during and right after the infection to make sure it's cleared. And then the IgG is the longer-term antibody that your body keeps around in case this ever comes back again. And when you're asymptomatic, you tend to have a low rate, and the studies have been coming back of this happening. So it doesn't mean that you're not immune necessarily. It just means that your body killed it off so quick and did such a good job at killing off the virus that your body didn't need to make a whole bunch of antibodies to get the job done. Mild symptoms. So with people with mild symptoms, they'll have a little bit higher viral loads if that was measured. They're still going to be positive at the right timing. And they're going to have a higher amount of level, more likely to have antibodies in their bloodstream. If the person had severe symptoms, became quite ill, they're very, very likely to have a higher rate of positive. So that's why we're seeing that amongst the antibody testing, the elderly and the older people, they have a much higher rate of positives on their antibodies than those who are younger and had less symptoms or no symptoms. All right. All right, so this is, I think, probably one of the best graphs I've seen on this. It looks very involved, and I'll try to help you understand what you're looking at here. But if you understand this graph, you will understand COVID-19 as it interacts with your body, and it'll help you clear up a lot of discussions that are going on. All right, so let's look into this here a little bit. So the time starts here and it goes this way. So you got week -2, week -1, and so on going along. And so you get exposed to SARS-CoV-2. So right here, you get exposed. And so from that very moment, if you were to check a swab of the PCR test, so that looks again at the viral, what's going on with the virus, that will start to be positive for up to a week, but usually it's within 2 or 3 days you're going to be predictably positive before you have symptoms. And then your symptoms start right here. So you start feeling, some cough, or start feeling tired, start having a fever, depending on the size of the dose. And then you're going to stay positive on your PCR for up to, on average, right here. So the way they drew this, this is actually much longer, but this would be a person with a very severe case. So if they were still positive at week 4 and week 5 and week 6, they would have had a very strong dose, very strong response, and those people usually take quite a bit longer to clear the virus out. But on average, most people are clearing it right here. So after this point, so day 17, on average, people go negative on their PCR in their throat, in their nose, okay? So that's how that works. So here you have the virus. If you were to isolate the virus from the respiratory tract, it goes up like that. And so during this time right here is when you have the live virus in your body. So negative week 1 and week 1 up to about day 9 to 10. After day 9 to 10, they really have not, especially in mild to moderate cases, asymptomatic cases for sure, they have not identified the virus being able to be live. So, some people might take issue with me saying live virus because, some people question whether it's something that's alive. But what I mean by that is that the virus can replicate, can make someone else sick. So after you've had the symptoms for about 9 to 10 days, and you have a mild to moderate infection or asymptomatic infection, you are not going to make people sick anymore. And that has been reproduced in when I looked at the review on this, 79 studies showed the same thing. And so if you are hospitalized or you're very, very ill in the ICU, you're going to have a little bit of different story. Generally speaking, those people are, on average, depending on the person, somewhere around here to here, start to go negative. So it takes them a little longer to go negative in terms of the virus being able to be replicated and in another person. So it could be passed to another person. So that's very, very important to know. So the local health department here in Chattanooga, from the very beginning, they've been doing this, just based on principles they know from prior, outbreaks, etc., that basically 10 days of isolation is what they've been recommending to many people when you start having symptoms. And that's generally how it goes. If you look at bronchial alveolar lavage, so that's your sputum, that's basically pneumonia, that's the secretions from a pneumonia from inside deep in your lungs, that goes negative right around here on average. So you're looking at about 15 days, or 14 days, I should say. And then stool PCR. So this is when the virus goes negative in your stool. So it goes negative in your stool, about 17 days out. So realize that there's a big issue here. So you have this whole area where you have live virus where you could spread it to someone else that ends right around here, around day 9 or 10. And then you have virus that you're shedding, that's dead virus for multiple days more. And so you can go weeks sometimes shedding dead virus. And if you were to get tested again, let's say you got really sick with this and you get tested again at week 4, and you were one of these people that really took a long time for that shedding to end in you, you could test positive for coronavirus again. And that doesn't mean that you got infected again. It means that you weren't done shedding the virus. And so you're not going to think that you have another coronavirus infected. Maybe you were having something else. And thus far, we have not been able to prove without a doubt that that is occurring. Maybe it has occurred, but generally speaking, there hasn't been any proof coming forward that I've seen. And the CDC says the same thing, that they have not seen reinfection occur as of yet. Okay, let's talk about assessing COVID-19 risk. So I was in the Dallas airport about a couple months ago, and obviously mask wearing was basically universal in the airport. And sometimes folks obviously were pretty scared of this, and we had folks in hazmat suits walking around, that concerned about passing this along, and it definitely got my attention. Assessing COVID-19 risk. So let's look at the risk mitigation strategies, the risk issues that are going on. So I was visiting Oregon, and Oregon has had really clamped down on things over there. And we went to go hiking at one of my favorite hiking spots there on the Oregon coast. And look at what it says there: trail closed. Oh boy, that was hard. But we did sneak a little hike in, but we were probably not advised to do that. What are the risks this year? So let's just take this into context. What are the risks on us in general? Obviously, depending on your age, this is going to change. This is just a broad look at this. Depending on your sex, etc., there's going to be various details involved that will change these odds. But let's just look at the odds in general. Americans, on average, have odds of 1 in 605 of dying of heart disease this year. 1 in 655 of dying from cancer this year. 1 in 1,300 of dying from an injury this year. And if you do the math based on how I was doing it there, you have about a 1 in 1,600 chance of dying from COVID-19. You have a 1 in 2,600 chance of dying from a stroke in America. 1 in 5,000 chance of accidental poisoning. 1 in 8,000 chance of a motor vehicle accident, dying from that. And you have a 1 in 14 million chance of dying from lightning. All right, so hopefully this gives us a little sense of our context here. I mean, how many of us are worrying as much about heart disease this year as we are about COVID-19? How many of us are concerned about cancer as much as COVID-19 or injury? And obviously, the age of the people makes a big difference. If you're younger, injury is a much more big issue. As you get older, heart disease and cancer and stroke play a much bigger role. All right, so I thought this statement from 2014, USA Today, actually they were looking at financial things. Look at this statement from Morgan Hauser. If the US news focused on the biggest threats we face, it'd write almost nothing other than poor diet, lack of exercise, and car accidents. It'd write about almost nothing other than those 3 things, which are probably 3 of the least covered topics. So I thought that was pretty good. And the title of this article was "Why We're Awful at Assessing Risk." And I thought that was pretty interesting to look at. And in this article, I thought it was pretty interesting that he gave this list of why we tend to overestimate risk in certain situations and why we tend to underestimate risk in certain situations. And so let's take a look at this in light of COVID-19. So this stuff was made up by Paul Slovic, who works at the Decision Research Institute. And let's see if how COVID-19 fits into this scenario here, this list. So catastrophic potential. Lots of people affected at once rather than in small numbers over time. So check on that. Oh, I guess I gave it all away there. Familiarity, a risk that isn't common knowledge. We weren't familiar with COVID-19 when it came out. Understanding, a sense that something isn't well understood by experts. We definitely were feeling that way when it first came out. Personal control, a sense that danger is outside your control. There's things that you're not sure what you can do. Voluntariness, something can do harm even when you don't voluntarily put yourself in danger. So that is certainly true. Thankfully, the children, for the most part, there are exceptions, but for the most part have not been affected. This victim identity, where you start feeling like a victim, is maybe not. Maybe there's some instances of that, but generally I'm not seeing that so much. Origin, man-made risks are viewed as more dangerous than natural disasters, and so it's probably more. This is probably more of a natural disaster, but some of the reporting early on, the way it was characterized, made it feel like a man-made risk, didn't it? And so I thought that several of these made us tend to actually overestimate the risk. And no doubt this is a serious issue. This can absolutely kill you. It can kill your loved one. But I think it made it seem like it was equivalent to the Black Plague at first. At least that's the impression that I was getting as I was looking at things. All right, current status of COVID-19 in Hamilton County, Tennessee. So let's take a look at some of this data. It's pretty interesting. So a number of new COVID-19 cases reported. So here's how we've done here since March. We basically had very little going on until about May, and then started to rise a little bit in May. And we've just slowly been kind of trending up, I think, because of the fact that we were kind of late to the game down here in Tennessee, and also because we don't have a lot of population density issues like they did in some parts of the East, Northeast especially. We have just been sort of floating along here and having a relatively mild experience with this overall. Obviously there are exceptions. There are some people who've had pretty significant problems. 60 deaths we've had now. That we've had 6,600 positive test results here in our county, 78,000 negative test results. So if you take 6,600 and you do a multiplying, kind of thing, these are basically exclusively PCR testing on these positive test results. So, what is it, 66,000 maybe, or could it be higher than that? Are we up to 100,000 people who've already had this? Hard to say. It's hard to say. And our case fatality rate has actually been pretty low with this, thankfully. That's just taking these numbers, this minus this, or divided by this, I should say. And so that's, we've done pretty well so far here in Hamilton County. The Brainerd area has been hit the hardest with 939 people have been confirmed positive. So there was quite a bit of an outbreak there. We also have this kind of in the southern part of the city there, in the main part of Chattanooga. We have quite a few cases there, 693 cases there. We also have, a fair bit up, kind of going up the freeway here, I guess more in Ottawa here, and the Hickson area, so on, has some cases, but nothing crazy, nothing that our hospital system can't help with. And so where are we at now? So that's the big question. Are we still rising on this? Are we falling? I've heard varying opinions on this. I don't think we have definitive data to say for sure. Probably the best thing to look at is, what are the hospitalizations? If something really is happening, then you'll see the hospitalizations going up, and you can't fake that. You can't mess that up very easily, with the way you're doing the testing and so on, in those comparisons. And so we've had, this is in the US, this is all of the US. We've had kind of a big rise there. And then we had kind of a fall for a bit. And I think this is when people were being pretty careful. And then we've been a little less careful. And now it's really starting to come down. And so the question is are we being more careful now? Or is the rate really starting to fall? And, I mean, I hope that it's really starting to fall. But we'll see what the conclusion is there. And we need to watch that carefully. All right, so what is the scale of this overall? Obviously, this is a serious issue. I mean, if you look at the number of deaths that we've had, it's in the top 20 in terms of known pandemics. There's lots of unknown pandemics where we have no idea how many people died, but it's definitely in the top 20. It's certainly not comparable to the plague or anything like that, not even close. But it's definitely comparable to the flu of 2009, 2010. If you take the swine flu and H1N1 and put them together, there's some fairly similar numbers there. This number I chose here is assuming that it'll get up to 800,000. That remains to be seen in terms of the numbers. All right, so in the U.S., we're at 5,170,000 cases, and hopefully this is going to slow right down. We're not going to see much more in the world. We're at the 770,000 mark in terms of deaths, and this is listed at 21 million. Obviously, that's a PCR number. This is a PCR number pretty much, and so you're going to have to multiply this by somewhere, if you go with the U.S. data, somewhere between 6 to 24 fold. Maybe that's a little bit different. Some of the analyses were going as low as 5-fold increases, so it could be 5 to 24 fold increase in terms of that number. So you can do the math and just see where we're at in the world. Obviously, it could be different than that since the testing is pretty different in some places. All right, so so the question is, where are we at? And I just put this up to kind of reiterate that. If we're up here at 124 million, through March through May, then if that doubled again, 150 million basically getting to. That is pretty close to herd immunity, and that's going to really slow down the epidemic. So we'll see if we're really that close, but we're that close in a couple cities in America, so that's good news. All right, so let's turn to some of these risk mitigation strategies. So we've been assessing risk. We have a kind of an idea of the risk that we're dealing with. Now, how do we live in our lives? And we've gone through this quite a bit in the news, but I just want to look at a couple of the most current things going on. All right, so stay 6 feet away. That's been kind of the mantra that you hear everywhere. And is it that simple? Is it really just that simple? You just kind of measure how far away you are from people, and you just stay 6 feet away, and that's all you got to worry about. Is that the main thing, or is there more to this? All right, and did we really flatten the curve? I think we did. I think we did flatten the curve some. I think we were a little late to the game. That's my opinion. We probably missed some of it, and it had already gotten to America faster than we thought. But we did slow it down. So we got to respect this virus. Stop respecting this virus, and it can kill someone you love. I think the number one thing for mitigating risk is what I'm calling, and I got this from David Katz. I think it's a great idea: total harm minimization. It's minimizing harms of infection while minimizing the harms of indiscriminate lockdown. So we've got to find that balance, and sometimes in our vigor and our zeal to slow this virus down, we've harmed our community by doing such vigorous lockdown that other parts of our world are harmed, and we'll look at that. Risk stratified set of policies. So taking a careful look at how we can best care for our own communities, rather than just indiscriminate things. Overwhelmingly mild disease in young, healthy people. So that's a good thing. That there needs to be a bit of a different strategy with young, healthy people than and those who are elderly or with chronic diseases. Of course, in America, we've got a big problem because we have a very, very large obesity problem, and many obese people think they're perfectly healthy. And when they get exposed to the virus, they get a lot sicker than they thought they were going to get. And so that's a problem. We are poor at assessing our own risk. So here's a graph that kind of looks at this total harm minimization idea. So we want to be somewhere in the middle, right here. We don't want to totally ignore the infection and have very high rates of illness and death. But indiscriminate lockdown has led to a lot of loss of jobs. We've had plenty of failed businesses. We've had loneliness issues, depression, anxiety, or the suicide rates have gone up. And that's not good. And we should not just ignore those things. That is a bad, bad idea. And we have, and in some cases, in some places, and it hasn't been very, very good. So we want to find a balance. It is okay to leave the house. It's good for your health, and that's okay. But we need to know the risks in our own area. You don't have to wear a mask in the car or when you're about by yourself, okay? I just want to say it because no one's been saying it. You don't have to wear a mask in the car. Nobody's going to infect you in your own car. All right. So let's mitigate our risks. So obviously the distance from others, the time spent with others, the activities that we're doing with others, the environments that we're in, and our personal health and age all play a big role in mitigating our risk. And I just wanted to show you this. I'm not sure if this will come through, but yeah, here it is. Okay, so this is a very incredible website. This is called covid19risk.biosci.gatech.edu, and this is from Georgia Tech.
Greg, I don't think we can see it. We're just looking at a white screen there right now.
You can't see that?
Oh, no, it just looks like a white screen.
Oh, man. Sorry about that. Let's see if I can get that up. Let's share it this way, and then we'll have to go back to the other. Can you see it now?
Yes, we can see it now.
Okay, so this COVID-19 event risks assessment planning tool. I thought this was really neat. So what you can do is you can look at your event size. So say you want to have a big event or you want to have a little event, you can scale it up or down. So let's just take a little event. So 10 people. And so then you can look all over the nation, and you can assess the risk in your own area. So let's see if I can dial down here to Tennessee. So, here in Hamilton County, we have more cases right now. We still have quite a few cases going, and so our current risk level is 27%. So what that means is that the chance that there's at least one person in those 10 people is 27%. So, so if you have 4 of those groups, that had 10 people, in a certain area, on average, one of those groups will have a person who could infect others. So if you go in over to Marion County, it's only 14%. Franklin County is 20. Lincoln County is 23. Riley County is 34. McMinn County is 21. Catoosa County in Georgia is 22%. But if you back it up and you go to some of these other places that are, that are pretty, relatively rural, it can be less than 1%. It's just not likely to be occurring. Or there's some places that have had the virus, kind of, really going on for a while here, and maybe, the risk is a lot less now because there's just nobody who has it anymore. And so if you look in places in New Jersey, you're down at 5, 6, 7%. You look at Long Island, you're looking at 3 to 5%, whereas it was very bad before. Look in Connecticut, 2, 3%. So, you're definitely getting pretty low there for 10 people to meet. You're still, we're still having issues here. Over in California, San Bernardino County, 30%, Kern County, 51%. So you know, it varies a lot. You know, then we have just little isolated spots here. Clark County, Idaho, 81%. Bighorn County, Montana, 79%. So there's a lot of people who are going through it. It's kind of the outbreaks going on right there, right now. So I think this is a great, so if you want to meet with people, keep an eye on this website, and they are monitoring the data and trying to give you some estimate of how things are going. So I thought that was really good. All right, so I'm just going to load the thing up again. Let's see, where did it go? Give me a second here as I figure out my technology here. Let's see, maybe I did something wrong.
While you're doing that, Greg, I just want to point out that the fact that someone is there doesn't mean you're going to catch coronavirus from them. The chance of transmission is still, it's not 27% if you get 10 people together. It would be markedly lower than that.
Yeah, right. Absolutely. Like, you know, for example, even in your own family, and I'm going to get to this in a second. There we go. Even in your own family, let's see, I'll go back here. You have a 1 in 5 chance of catching it from another family member who has it in your own home. I mean, that's what the research shows. So, we, you know, it's certainly not 100%, not by any means. Okay, can you see that again there?
Yes.
I'm getting better at Zoom. All right. Okay, next we go. So we're mitigating our risk. So we want to think about things in a nuanced way. It's not an all or nothing thinking here. And so we got to think about the distance from others. We got to think about what environment we're in, you know. Sometimes, you know, when you're very close to others, it'll take a while before you're at significant risk of infection. In fact, you know, the cutoff is 15 minutes most of the time in most studies. Whereas there are situations where you could be quite a bit farther. They had multiple reports from restaurants where they did these detailed analyses of who got sick and where they were sitting. And many times they were quite a ways from the actively infected person, but they got it because the ventilation in the restaurant was poor, and people were sitting there for a long time together, and they picked up the virus because they're breathing contaminated air. So time spent with others is very, very important. So you know, if you're closest to a group of people, that means less time that it's going to be a lower risk kind of thing, and you should probably wear a mask in that situation if you're gonna be in that kind of setting. Obviously, singing, shouting, car rides, sitting together for a long time, eating together, those are the high risk moments, and you got to think about how much time you're together, what the flow of the air is there, etc. If you're outside, the risk is lower than indoors. The temperature and air movement, like I said, amount of time others are in the room. So if someone's been in the room a long time, it's a small unventilated room. If they are 1 day away from having, you know, feeling symptoms, they're at higher risk than somebody who is who has just showed up at the same time you have. And then your personal health, which we touched on. So let's take a scenario. So here's a group of people. We got 9 people here. They're having a picnic together. It's a family gathering. And they're outside together. They're trying to be a little more careful because of the outside situation. So what's the risk? I mean, you know, what should these people do? You know, should everyone act the same? Should different people do different things? Looks like they're going to eat together or have eaten already. You know, how should we go about this scenario? So the fact that it's that it's a outdoor thing significantly lowers the risk. But if they're sitting there a long time together, and let's just say, let's pick a person. I don't know. Let's say this guy right here. He doesn't look like he's feeling that well right there in that picture. I mean, obviously you can't tell just by a picture, but let's say he's sick right now. So if he's coughing a lot, probably you would tend to get up a lot quicker, and maybe make your interactions a little more brief than if he's breathing comfortably there. You can feel the direction of the air. If the air is moving from where the cameraman is towards the screen, towards that table, then the air is generally moving away from the people, and they're not necessarily going to contaminate each other all that much. This guy, if the air is moving away, going that way, then he's probably not going to contaminate this lady or that guy, and maybe this guy is at the biggest risk there. So it's something you gotta think about. You gotta decide your own risks, how you're going to go about these things. In this area, we still have a fair amount of virus going on. So, if you're a gentleman, let's say this guy has heart disease and he's got high blood pressure and he's got diabetes, he's at significantly more risk if he catches from this guy than, a younger person or someone who doesn't have chronic illness. Let's say this lady doesn't have anything, if she catches it, maybe she'll hardly notice, but this guy will get sick and end up in the hospital. So, depending on who you are, you need to mitigate your risk and think about it from that standpoint, and just realize that we tend to underestimate things sometimes or overestimate things sometimes, and you want to get a balance there. Okay, here's another scenario. We're in Costco. Costco and all the stores right now are kind of making you wear a mask, so you got to wear one. But people are pretty spaced out. How much time do people spend in Costco on average? Probably 30 minutes, 15 to 30 minutes, something like that, maybe an hour in some cases if you're buying a lot of stuff. So the amount of time that you're in the store is relatively low. And if everybody's doing that, then it's probably a pretty low risk environment. There's a lot of air there. It's better than a lot of places. And so that lowers the risk. They do have fans blowing, and they've got, ventilation going on. People are standing apart from each other. So, in my mind, this is a pretty low risk environment as long as you're not there for a long, long period of time. Probably the people at the highest risk are the people who are there all day. Even so, everyone's wearing a mask. This is a very low risk situation. Almost nobody, I've not even heard of any outbreaks occurring when this kind of stuff is going on. How about this kind of environment? Here they're having a church gathering, and they're having a little church meeting or something. And the people are all sitting together. It's in maybe a relatively old building. It's got poor ventilation. And, quite a few elderly people there. And if they meet there for an hour, what's the likelihood that multiple people are going to get sick? If somebody is infected right now in that room, it's probably a third of them, would probably get sick. So, if you're singing together, say they were singing together, then it's more like 50 to 60% would get sick being there an hour. All right, so let's look at the masks a little bit more just in regard to this issue. So the N95 masks are the best by far. There's very few, as I've looked at this research more and more, there's very few studies that even the surgical masks are comparable. Oh, I see, I got an error there. This is supposed to be 80 to 90%. N95 masks are the best, but not comfortable. They are not comfortable. I wear one every day at work, and they're not that comfortable. They have a very tight fit on your head. The back of your head starts hurting after a while to keep adjusting it. They're not as available, but they're excellent. They have 95% plus filtration, preventing the filtering. The filtration means filtering the virus. If you cough or if you breathe through, and so that's excellent. Most surgical masks are somewhere 80 to 90%. I've seen a few on the CDC website as low as 50 to 60%, but most of the masks are from reputable brands that most people wear, and so they're pretty good. They have a pretty good situation going on. Of course, it depends on the fit. If the fit is poor and it's not really on your face very well, it's not going to work very well. The homemade masks, which is by far, it seems like in the community is by far the most common thing. Some of them are pretty bad, and some of them are better. And this has been a interesting learning experience. The homemade masks that have at least 2 layers of high quality, heavyweight quilters cotton, so very tight thread count, 180 or more. One study showed a 79% filtration, so that's pretty good. I mean, that's quite manageable. A lot of people who make the homemade cotton masks, some of them are less, a lot of them are less than 50% filtration. And so especially one way to judge your mask is shine it up to the light, show it up to the light and see if you can see light through it. If you can see light through it, then it's not a very good mask. And they've had some of these lightweight type single layer cotton masks. They achieve as little as 1% filtration. So they're pretty poor in terms of their ability. So, there's a wide variety of quality here, and try to find the best quality you can if you're going to have to wear a mask. Obviously, the situations you need to wear a mask in is primarily when you're having to be in close contact with somebody for several minutes. That is the number one reason why. And I think some of our mask wearing, just in the whole community, some of it, in my opinion, is overkill. But the most important thing is when you're with other people for some minutes. All right, and then I wanted to say a couple things about what we're doing in the hospital. So COVID-19 treatments that we're giving. So we're getting a lot better, as far as I can tell, at caring for patients in the hospital. Our death rates are definitely improving on that end as well. We're using a medicine commonly now called remdesivir. It's gotten an approval by the FDA in an emergency way. It was used in the first SARS, and they had good success with it. It does shorten the number of days in the hospital by about 3 days, maybe 4 days. So you're looking at many times 7 to 14 days in the hospital, depending on how ill the person is. So remdesivir does have a substantial improvement. I've seen some good turnarounds with that. We're using oral dexamethasone because of these. Some people have an abnormal immune response when they interact with the virus. So the first part of their immunity with their T cells, where they're just getting the initial response with their body before the antibodies have started, that can be abnormal, and so that can lead into an abnormal cytokine response, we call it, and the dexamethasone significantly is improving that. It may prolong the hospitalization a little bit, but it's keeping people alive, and it's lowering their risk of death by about 20%. Proning, so that's laying on your stomach. So if you get coronavirus and you're at home and you're feeling a little short of breath, lay on your stomach. And that improves the amount of fluid going out of the lungs and can help you to feel better. We are using convalescent plasma in patients requiring supplemental oxygen. It's an experimental thing. We're not sure for sure if it works or not. We have experience in prior illnesses when we're in this kind of situation that it may be helpful. I've not seen any severe complications from it or anything, but it is a blood product, and obviously there's the risks therein. And then hydroxychloroquine. I gave hydroxychloroquine to several patients early on when we had very little to go on, and there was a couple studies showing maybe that it was very questionable, but I didn't see that it did anything in hospitalized patients. It didn't have any effect. And it has a risk. We had to check EKGs every day, and we had to keep a very close eye on the patient's risk of arrhythmia, because hydroxychloroquine causes an increased risk of arrhythmia. And so I think that's the biggest concern that we have, having people taking it maybe for prevention or for treatment in the outpatient setting, is that some person may have heart disease and not even realize it, and then they're taking hydroxychloroquine and it increases your risk of arrhythmia, and COVID-19 increases your risk of stress on the heart significantly and sometimes. And so it's been kind of a questionable thing, and until there's research that I see proving that it's helpful in the outpatient basis, like I know for sure it's not helpful in the inpatient basis. I don't recommend it. Factors affecting our immune response. So this is the last section here. So the amount of dose that you get when you are exposed to COVID-19 is one of the most important things, and it really hasn't been discussed much at all, as far as I have heard in the media or in various talks, etc. But how much virus that you get into your body when you get infected is a very important piece. If you have a very low dose, your body's not going to have nearly as much of a fight as if you have a very strong dose. So if someone coughs in your face, or if you have a prolonged time in a small non-ventilated room with a coughing person, or you're singing with multiple people in a large room, especially for a long time, you're gonna face a much higher dose potentially. Being with people in your own household, the risks are, I think, there, but are lower than those first three I stated. Because on average it's about 20%, like I said. All right, so we'll just jump over that. So minimize chronic inflammation before you're exposed to COVID-19. So what we've focused on many times in Dinner with the Doctor is some of these basic issues. And there are lots of research studies showing improved immune function with things that I am listing below. A healthy diet is huge. Two of the most important pieces that have to do with your diet are how much sugar you're taking in. If you take in 10 to 14 teaspoons of sugar in one sitting, so that's like one large soda or a large dessert, you're going to suppress your immune system for up to 4 hours after that. And the innate immunity, though, the part of your immune system that's really important when you're first exposed to COVID-19, is suppressed for 4 hours. And so you don't want to put your body in that situation, if you can help it. Getting a healthy weight, that is so important with COVID-19. We don't understand why this is so far. We know that there's some abnormalities with the way a person's immune function works when you're overweight, but we don't have a full knowledge as it relates to COVID-19. But we know for sure that you're much more likely to get severe COVID-19 if you're overweight or obese. Sleep. If you're chronically sleep deprived, you are much more likely to get an upper respiratory infection, and that's a very important piece. Moderate exercise is very important. Exercise stimulates the heat in your body, and putting your body through repetitive heating exercises, as we were learning in our thermal study, it gives your body practice, gives your immune system practice for when the real thing shows up. And so regular amounts of exercise is very important, and only about 20% of Americans exercise. We know we're supposed to do it. We've heard a lot of good things about it, but we don't do it. And that's one thing to really see if you can get done in your life, is get some exercise going. Healthy relationships. This is an issue that has been harder, I think, during COVID-19, is to maintain healthy relationships when you can't be with people as much, and that's something that does play a big role in our health. Getting fresh air is a huge thing in COVID-19, I think. And if you're going to meet with people, or you're going to organize some kind of thing with people, try to find a way to get it outside. It's going to lower the risks a lot. Performing forest bathing, I love this term. If you're in a natural environment that has a lot of trees around it, those trees literally are stimulating your immune system while you're in the forest. It's amazing. The research is there. Overwork, if you're working excessively. And I've seen this probably a handful of times now with patients with COVID-19. They come in the hospital, they're very sick, we get them through, and then they get better, and then they go home, and then they start working too much, they start doing too much, not paying attention to their hydration, they're not paying attention to their sleep, etc. And guess what happens? The inflammation rises again in their body. It doesn't mean that the infection is necessarily coming back, but the inflammation comes up again, and they start feeling ill again, and lo and behold, they come back with dehydration into the hospital and spend a few more days with us. So it's something to be very careful when someone's recovering from COVID-19, is to continue to rest enough, have balanced life, and make sure you're fully recovered before you go back to work or start doing significant projects. Seek spiritual resources. This is an important thing, with all the fear and anxiety and issues that are going on related to this epidemic. The spiritual resources that are in your life play a huge role, and don't neglect those. All right, so we'll just skip through this for lack of time. I really love this thing. My wife thought it was too busy, and it probably is too busy, and we've gone through most of these already. But this is where you want to be. You want to be over here, and you don't want to be over here. And so these are the risk factors for COVID-19 that I've seen, and they do play a role in how sick you're going to get if you're exposed. Another thing that I think is important is people who are zinc deficient. We know generally with most upper respiratory infections that there's an improvement with zinc, and I think that it definitely decreases the incidence. We know it definitely decreases the incidence of infections in the elderly, especially. The elderly are often zinc deficient, and it's testified by the fact that many elderly have a lack of taste. The food doesn't taste right, and one of the more common causes of that is zinc deficiency. So eat zinc-rich foods, eat the healthy zinc-rich foods. So just a little plug on some dietary stuff. Eat those baked beans, 2.9 milligrams of zinc there. I didn't go over the details of that. So, if you're 19 plus years, you need 11 milligrams a day, or a female, you need 8 milligrams a day. So males need 11 milligrams, okay? So we can get it. It's not too hard. 1 ounce of pumpkin seeds, 2.2 milligrams. Zinc supplemented breakfast cereal, 2.8 milligrams. Dry roasted cashews, 1.6. Chickpeas, 1.3. Oatmeal plain, 1 packet, 1.1. 2 slices of bread, whole wheat bread, 1.0 milligrams. Almonds, 0.9 milligrams, 1 ounce. So that's easy that doesn't take much at all. Kidney beans cooked, half a cup, 0.9 milligrams. So it's our beans, our nuts, our seeds. These are the big ones to focus on when it comes to getting enough zinc. For Brazil nuts. Brazil nuts are great for men. They help several things in men. Getting the zinc in, really good idea when you want to prevent getting sick with COVID-19. And some of these details may be why people are have varying things with that. All right, so we went over the good news. I think there's a lot of good news here. I think things are getting better in terms of our knowledge and our understanding. We have a better understanding of the risks. We have a better understanding of what is not happening. We know a lot more about the viral dynamics and what's going on in our body. We talked about assessing risk and trying to have a balanced approach to that. And it's not easy to do when you're trying to figure it out in your own life, in your own various organizations that you're part of. But each organization, I believe, each person needs to take a careful analysis of these things as we continue to go. Hopefully this epidemic is starting to die down in this area. I think we're one of the later areas in terms of risk. Hopefully that's the case. Factors affecting our immune response. We went through some of those details. Some of these things hopefully you've heard before, and I just want to wrap it up there.